Okay, I think we're going to get started. Thank you everyone so much for joining or selecting the importance of overall healthcare maintenance breakout session. My name is Kelly Fitzgerald and I am the Manager of Education and Engagement at the Crohn's and Colitis Foundation. As a reminder, you may enter questions you have at any time in the Q&A box throughout the presentation, and we should have time at the end to ask questions. Without further ado, I would like to welcome our breakout session speaker, Dr. Sashidhar Sagi. Dr. Sagi is a board-certified gastroenterologist and assistant professor of clinical medicine at Indiana University. His clinical interests include diagnosis and management of inflammatory bowel disease, microscopic colitis, GI bleeding, chronic diarrhea, C. diff colitis, colon cancer screening, and celiac disease. His research interests include clinical trials of new therapies for Crohn's disease and ulcerative colitis, fecal microbiota transplantation, and liver problems in inflammatory bowel diseases. Dr. Sagi, I'm going to pass it over to you.
Thank you, Kelly, and welcome everyone to this breakout session. As you all heard from Dr. Siegel about how important it is to take care of the inflammatory bowel disease, not only in terms of symptoms, but also to make sure that the targets are reached in terms of mucosal healing to achieve long-term goals of well-being. And what I'm going to talk about is well-being as a whole person. And what I mean by that is the importance of overall healthcare. And what I don't have any relevant disclosures. What do we mean by health maintenance? And what it means is a program or a procedure to prevent illness and to preserve or promote health. What does this mean in the context of IBD? Next slide. It means reducing or decreasing disease-related complications and minimizing treatment-related adverse effects, and thereby this is all part of what is called whole person care. Next slide. What are the components of health maintenance in IBD? And this includes vaccinations to prevent infections, and also colon cancer screening, specifically colon cancer screening for cervical cancer and skin cancer. It's also important to screen and maintain bone health. A big component of overall well-being is mental health, which should be another important aspect of overall well-being. And smoking, specifically smoking cessation for long-term health maintenance. Patients with IBD are at an increased risk of infection when they are on immunosuppressants. And often IBD patients are treated with the immunosuppressants, which include steroids, immunomodulators, and biologics. Infection risk is higher when taking multiple medications, particularly combinations of steroids and immunomodulators or immunomodulators and biologic medicines. And also the infection risk increases with age, particularly above the age of 50, there is a significantly increased risk of infections. But one very important thing to remember is that many infections are preventable with vaccinations. Next slide. Take the example of the common flu. There is a higher rate of infection to the tune of 50% in patients with IBD compared to controls. And also there is a higher risk of complications with more than double the increase in hospitalization rates with influenza in the context of IBD compared to controls, and also a much higher rate of pneumonia in IBD patients compared to controls. Steroid treatment has been shown to independently increase the risk of pneumonia or increase the risk of influenza in IBD patients. Hence, all adult patients with IBD should undergo annual vaccination against the influenza virus, and it is recommended to take the inactivated vaccine just to avoid confusion about the live influenza vaccine, which is the flu mist. Again, pneumonia is another infection which has a higher rate to the tune of 50% in IBD patients. There is also a much higher risk of death with hospitalization with pneumonia in IBD patients. Steroids tend to increase the risk of pneumonia in IBD patients. There are 2 vaccines available for pneumonia prevention, and IBD patients on immunosuppression should undergo vaccination with both of those vaccines. One is the 23-valent Pneumovax, and the other one is the 13-valent Prevnar 13 vaccines, both of which are inactive vaccines and are recommended for all patients with IBD. Other infections to consider in patients with IBD are there is an increased risk of hepatitis B reactivation in patients who are on anti-TNF therapy, which is a class of biologics that are commonly used in treatment of inflammatory bowel disease. Infection with the human papillomavirus has been associated with both cervical cancer and anal cancer. And there is an increased risk of shingles with just having inflammatory bowel disease, and also various treatments for inflammatory bowel disease, which include steroids. There is an increased risk with anti-TNF agents, as well as with certain small molecules like tofacitinib, which is a newer oral small molecule used in the treatment of ulcerative colitis. Not all immunosuppression in IBD is the same. And it's important to recognize this because patients who are on immunomodulators or prednisone or other steroid equivalent doses of 20 milligram, less than 20 milligram for less than 2-week duration are considered to be at low level of immunosuppression. On the other hand, prednisone doses of 20 milligram or higher for 2 or more weeks, or being on biologics or small molecules, is considered to be a higher level of immunosuppression. And the reason this is important in the context of vaccination, next slide, is because vaccination in low-level immunosuppression is safe for all vaccines, and this includes live virus vaccines. On the other hand, individuals who are on high level of immunosuppression should avoid live virus vaccines. I'm going to address the elephant in the room, which is the vaccination for COVID-19. And fortunately, we have guidelines now from the International Organization for IBD, which were published in January this year. And all IBD patients are recommended to get vaccinated against the SARS-CoV-2 virus, which is the virus that causes COVID-19. And the best time to administer the vaccine is the earliest opportunity to do so. And what this means is not to wait for a particular type of vaccine, not to try to time the vaccine in relation to the timing of medication. So in other words, as soon as you can get it, please go and get it. And also, all SARS-CoV-2 vaccines or the coronavirus vaccines so far are inactive vaccines and are safe to administer in patients with IBD. And again, this is emphasized that vaccination should not be deferred because a patient with IBD is receiving immune modifying therapies. This is the current adult recommended vaccination schedule by the CDC. This is a very busy slide. I don't intend to go through this in detail, but the reason I put this up is because this vaccination schedule applies to all patients with IBD who are on low-level immunosuppression or are not on any immunosuppression. Next slide. In patients who are on high-level immunosuppression, the only vaccines that are contraindicated or should not be administered are the live virus vaccines. And as you can see, these are 3 vaccines that are highlighted in red. One is MMR, which is the measles, mumps, and rubella vaccine. The second one is varicella, or the chickenpox vaccine. And the third one is the live zoster vaccine. In other words, the live shingles vaccine. Fortunately, we have an inactive shingles vaccine, which is the recombinant zoster vaccine that you see just below that. So even in patients who are on high level of immunosuppression, all of these vaccinations, and this includes the annual influenza vaccine, the tetanus vaccine, which is recommended every 10 years, the inactivated zoster or the shingles vaccine, the human papillomavirus vaccine for both men and women up to the ages of 26, pneumonia vaccine, which is what the PCV13 and PPSV23 refer to, which we alluded to earlier, hepatitis A and B vaccination, as well as vaccination against meningococcal meningitis in adolescents is still recommended at the appropriate ages. Next slide. March is Colon Cancer Awareness Month, and many of you who are members of the CCFA might have received emails indicating the importance of pursuing colon cancer screening and surveillance in IBD. And it's important to remember that patients with IBD who have colonic involvement are at an increased risk of developing dysplasia or precancerous changes in the lining and colorectal cancer. And colorectal cancer screening is recommended with a colonoscopy starting 8 to 10 years after the diagnosis of IBD in individuals with ulcerative colitis extending beyond the rectum, or in individuals with Crohn's disease involving more than a third of the colon. There are certain exceptions to this where colon cancer screening is recommended even earlier. For example, patients who have primary sclerosing cholangitis, which is a condition which affects the bile ducts, they have a significantly increased risk of colorectal cancer and are recommended to undergo annual screening right from the time of diagnosis. Further surveillance interval after the initial surveillance colonoscopy is tailored to the individual's risk factors based on their family history, the extent of disease, and the severity of involvement, as well as any prior history of precancerous changes in the lining. Cervical cancer screening is another important aspect of health maintenance. Cancer-causing human papillomavirus causes cervical cancer, and being on immunosuppression increases that risk. So it is recommended to get HPV vaccination in girls or women aged between 9 to 26 years. And again, as I emphasized earlier, this is not only just for women. Getting vaccinated for HPV in men also decreases the risk of transmission of HPV and thereby reduces the risk of cervical cancer. An annual screening with a pap smear is recommended for women with IBD who are on immunosuppression. Despite having 3 annual normal pap smears, it is still recommended in patients with IBD to get annual pap smears if they are on immunosuppression because of the increased risk. There is an increased risk of skin cancer in individuals with IBD. The risk of melanoma is increased by about 37%, and this is further increased in patients who have been on anti-TNF agents for more than 1 year. There is a 3 to 4-fold increased risk of non-melanoma skin cancer, which refers to squamous cell skin cancer or basal cell skin cancer with thiopurine use. And what that means is these are medications like azathioprine and 6-mercaptopurine. So all IBD patients should follow a program of sun protection and skin surveillance. And it is suggested that patients starting or already those who are already on immunosuppressive medications should be evaluated by a dermatologist periodically, and surveillance strategies should be tailored to the individual's risk and prior findings. And so, in other words, once you establish with a dermatologist, the surveillance intervals should be determined based on individualized risk. Bone health is another important component of health maintenance. And patients with IBD are at an increased risk of loss of bone mass. And this is due to steroid use, chronic inflammation, calcium and vitamin D deficiency, as well as malnutrition. Bone mineral density screening is recommended in IBD patients in women aged 65 years or older, or in men who are more than 70 years of age, or individuals who have had a prior fragility fracture, or in individuals who have had consistent steroid use of more than 7.5 milligram of prednisone per day for longer than 3 months. Depression, anxiety, chronic pain, and fatigue are all common in chronic illnesses, and IBD is no exception. Up to 20% of IBD patients have anxiety or depression, and many patients report stress exacerbating IBD flares. And even brief behavioral interventions have been shown to be beneficial. Non-medical options for patients who have depression and anxiety include cognitive behavioral therapy, hypnosis, and mindfulness meditation. There is data indicating that having mental health issues addressed and developing better coping strategies reduces the need for ER visits and improves compliance with medication as well as long-term outcomes. Smoking in Crohn's disease is associated with development of the disease, disease progression, and poor medical and surgical outcomes. Hence, patients with Crohn's disease should quit smoking. Though ulcerative colitis benefits from smoking in terms of disease control, the adverse effects of smoking far outweigh the benefits, and smoking cessation should be considered in all individuals with IBD. This is a checklist that is published by the Crohn's and Colitis Foundation for health maintenance in adult IBD patients. And this goes over all of the vaccinations that we went over earlier, as well as the cancer prevention strategies, as well as bone health, smoking cessation, and annual mental health screening. So in summary, in addition to following up with your gastroenterologist and making sure that your disease is in remission, both in terms of symptoms and also with objective markers like endoscopy or stool tests, it is essential to follow up regularly for health maintenance with your primary care physician, with your gynecologist, and as well as your dermatologist. And it's very important to address mental health issues, as there is a significant impact on overall health from mental health issues, and to avoid smoking. Thank you all for your attention, and thank you, Kelly, and to the CCFA for this opportunity. I'll be happy to take any questions.
Thank you so much, Sashi. That was very informative, and we really appreciate you joining us tonight. So we do have a couple questions that have come through. So I will just kind of roll through them and see what we can do. Okay, so someone asks, could you describe the status of research on fecal biotherapy or transplant, particularly for ulcerative colitis?
There are studies which indicate some benefit with inducing remission in ulcerative colitis, but the studies have not been consistent across the board. So some studies have shown benefit while others have not to the same extent, and often the degree of stool transplantation or the frequency of stool transplantation that is needed to induce remission is quite frequent, and sometimes to the tune of five times a week. So this is still in the research realm, and it has not come into clinical practice yet.
Okay, thank you. We have a couple of questions surrounding the COVID vaccine. Mm-hmm. So the first one is, if someone is starting on treatment like Stelara in a couple weeks, which is there a COVID vaccine that would be best? And what would be that timing you might recommend?
I think, I alluded to this. The international consensus panel from the International Organization of IBD, of which Dr. Siegel is the lead author on that guideline and guidance, they specifically indicated that no patient with IBD should wait regardless of the immunosuppression that they are on, or if they're even being planned for starting immunosuppression. So the current recommendation is not to wait for getting the vaccine. It's important to get the vaccination first. Though there are some concerns that the antibody response or the immune response may not be as robust if you were not to be on immunosuppression, that has not been shown even in other situations to correlate or imply that the protection would be inadequate. So again, in the absence of data and with the severity of the infection and with the individuals being on immunosuppression, it is recommended to go ahead and get the vaccine at the earliest opportunity. And there's no recommendation about trying to get one vaccine or the other.
And I know you just mentioned that there's not a lot of available data yet, but are we seeing anything about would it be less effective in patients with IBD?
As I mentioned, there's no data to indicate that. We have only one large published study, which was published in the New England Journal about the experience in Israel with the Pfizer vaccination, but I'm not referring to IBD in this context. And across a broad range of population, they saw that in individuals who have multiple comorbidities and who have an advanced age, it may not be as much effective. And again, I want to emphasize that this does not apply to IBD. But overall, these vaccines have been very effective, and the efficacy of these vaccines overall in preventing the serious manifestations of the coronavirus infection, specifically hospitalization, need for ventilation, or death, is above 95 to close to 100% with all of these vaccines. In fact, most of the studies are 100% in that aspect. So there is no specific recommendation because of that reason to avoid or to prefer one vaccine over the other.
Okay, great. Thank you, Sashi. Another different vaccine question. Someone's asking, should IBD patients get both flu vaccines every year? I think there's only one flu vaccine, right? Or is there?
There's the inactivated flu vaccine.
Mm-hmm.
The flu mist is a live vaccine. And in individuals who are on higher level immunosuppression, it should be avoided. But in general, the flu shot, which is the inactivated vaccine, is widely available, and that's what is recommended for everybody.
Perfect. Thank you. We're getting more come in, which is great. So what about some appointment questions? So because of COVID, they haven't seen their gastroenterologist for quite some time, just being safe. Is it safe now to schedule follow-ups? Should we go back on the regular maintenance visits?
All practices have adapted during the pandemic. At IU, we have been doing a lot of telemedicine, and I'm sure other places have adapted as well. And I think right now, even otherwise, it is very important to take care of health in all situations, and it's important to maintain health. So I would recommend, following up with the gastroenterologist. And many of our patients who have missed appointments are coming back, and we have different practices, I'm sure, have different options. And we have a hybrid model where if patients are uncomfortable coming into clinic, and we offer telemedicine. If they're comfortable and they want to see us in person, and they have that option. So. Okay,
great. Thank you. We have time for a couple more questions, and if we didn't get to any, we'll be sure to follow up later with questions or with the answers. So if someone is due to, we're on this definitely a lot of vaccine question, but if someone's due to get the shingles vaccine, how do they find out if it's live or not?
There are two shingles vaccines, and I'm going to put out the brand names here because that's the way to differentiate. Zostavax is the live vaccine. Shingrix is the inactive vaccine. And that's how you differentiate basically by the name. And certainly, whenever you're getting the vaccination, you should ask your healthcare provider what kind of vaccine it is, whether it's an inactive vaccine or a live virus vaccine.
Yes, great. And I think that's a good point too. A lot of these specific questions that I'm seeing in the chat that are pretty specific to individual care, I think it's important to reach out to your provider for some of those answers, and they can guide you along the way. Someone has another question about blood work. How often should blood and the calprotectin tests be done?
So that is a question, I think, for Dr. Siegel, who did the talk on treat to target.
Really?
But let me answer that, okay?
Okay.
So treat to target is this paradigm where we continuously monitor for efficacy of the treatment, and also to make sure that the disease is in remission. And that is something, we decide based on shared decision making. It's a discussion between you and your provider. And the recommended interval is anywhere between 3 to 6 months if the target has not been achieved. And that is a target that is defined by a shared decision between you and your provider. And if the target is achieved, which is a summary of making sure that you are in clinical remission, meaning that no symptoms, not requiring steroids, and some objective marker for remission, meaning either a stool calprotectin or colonoscopy. If that has been achieved, then again, it is 6 to 12 months. And that is a decision that is based on individual risk factors, disease history, and shared decision making with your provider.
Okay, great. Well, unfortunately, we're going to have to wrap it up this evening. Time flew pretty quickly. But again, I have the questions we didn't get to saved, and I'd be happy to go through them with Dr. Sashi, and we can get the right answers. So thank you so much for the excellent information. I'd like to thank you, Dr. Sashi, for leading tonight's breakout session and providing us with these great tips. And I would encourage everyone to reach out to your providers because they can definitely answer these important questions. I'd like to thank our audience tonight for joining us. Before we say goodnight, I just want to remind everyone to visit your local chapters either website or their Facebook page and social media page. Each chapter has been very busy at this time, planning just fun, creative, and safe ways for patients and families to join us this year. And we hope to see you at an upcoming event. Please don't forget to fill out our post-program evaluation surveys. Those will be sent out in email. And then we hope you can join us next month for the MyIBD Learning webinar series. The topic is the latest on genetics in the microbiome. So I hope everyone stays safe and is well and has a wonderful evening. Thank you so much for joining us.
Thank you, everyone. Have a good evening.
Have a great night. Thank you.